Hi, today I will be talking about hypertensive crisis. Hypertensive crisis is defined as acute severe elevation in blood pressure with systolic blood pressure greater than 180 mmHg and or diastolic blood pressure greater than 110 or greater than 120 mmHg. Hypertensive emergency, which is a subset of hypertensive crisis, is defined as acute severe hypertension with acute target organ injury. Hypertensive urgency is defined as acute severe hypertension without acute target organ injury. Malignant hypertension, also called as accelerated hypertension, is defined as acute severe hypertension with advanced bilateral grade 3 and grade 4 retinopathy characterized by flame-shaped hemorrhages, cotton wool spots, and or papilledema. Hypertensive encephalopathy is acute severe hypertension and one or more of the following: change of mental status, lethargy, seizures, and cortical blindness. Thrombotic microangiopathy is acute severe hypertension with Coombs negative hemolysis characterized by elevated LDH, low haptoglobin, cystocytes, and thrombocytopenia. The key target organs involved: brain, retina, heart, kidney, and large arteries. Acute conditions indicating hypertensive emergency in case of brain are stroke, hypertensive encephalopathy, cerebral hemorrhage. In case of arteries, it is acute aortic dissection, preeclampsia, and eclampsia. In case of retina, it is grade 3 and grade 4 hypertensive retinopathy. Case of kidney, it is acute kidney injury. And in case of heart, it is acute congestive heart failure and acute coronary syndrome. Pathophysiology for severe uncontrolled hypertension: pressure-induced natriuresis along with renin-angiotensin system activation can result in vascular resistance. Microvascular damage and autoregulation failure can lead to target organ damage. Cerebral autoregulation. Understanding the concept of cerebral autoregulation is a key in the management of hypertensive crisis. On this slide, we have on the x-axis mean arterial pressure from 0 to 200 mmHg, and on the y-axis we have cerebral blood flow from 0 to 150. Cerebral blood flow is relatively stable across a wide range of blood pressure as seen on this graph. Once the upper limit of autoregulation is reached, small changes in blood pressure can result in increased cerebral blood flow, causing cerebral edema. Once the lower limit of autoregulation curve is reached, small decreases in blood pressure can cause decreased cerebral blood flow, resulting in cerebral ischemia. The autoregulatory curve is shifted to the right in chronic hypertension. This can predispose them to cerebral ischemia if the blood pressure is abruptly decreased. The autoregulatory curve is shifted to the right in chronic uncontrolled hypertensive patients. This shift allows patients to tolerate higher blood pressure levels without developing cerebral edema, but predisposes them to develop cerebral hypoperfusion and cerebral ischemia at substantially higher blood pressure levels than in normotensive patients. Common causes of hypertensive crisis are medication non-adherence, use of drugs such as cocaine and amphetamines, withdrawal syndrome from alcohol and medications such as clonidine, use of medications such as non-steroidal anti-inflammatory drugs and high-dose glucocorticoids, use of high volume of intravenous fluids in the hospital. Secondary causes include renal artery stenosis, pheochromocytoma, Cushing's syndrome, and primary hyperaldosteronism. Treatment of hypertensive crisis. The type of target organ injury is a principal determinant in deciding the drug of choice of treatment, the target blood pressure, and the time frame in which the blood pressure is lowered. Hypertensive emergencies are generally managed in the intensive care setting with intravenous antihypertensive medications guided by the target organ damage. On the other hand, hypertensive urgencies are managed in the ambulatory setting. Patients should be given a rapid oral agent, and long-acting medication should be adjusted and should be discharged when the symptoms have improved and the blood pressure is less than 180 over 110 mmHg. Evaluation and management of acute severe hypertension. If the blood pressure is greater than 180 over 110 to 120 mmHg, which is reproducible on multiple measurements, one should evaluate for acute target organ damage. With respect to the brain, one should inquire and perform a neurological exam looking for any focal, motor or sensory deficits and speech or visual abnormalities. If there are positive findings, perform imaging with CT of the brain or MRI of the brain looking for stroke, intracerebral hemorrhage and posterior reversible encephalopathic syndrome. With respect to heart, inquire about chest pain, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Look for signs of heart failure on exam such as elevated jugular venous pressure, bibasilar crackles and lower extremity edema. Perform chest radiography to rule out acute pulmonary edema and electrocardiogram and troponin measurement to rule out acute coronary syndrome. With respect to retina, perform a fundoscopy looking for flame-shaped hemorrhages, exudates and papilledema. With respect to large vessels such as aorta, inquire about any chest pain relating to the back and obtain blood pressure measurements in both the arms looking for asymmetry. If suspicion is aroused, obtain a CT of the chest and abdomen with contrast. With respect to kidneys, obtain serum creatinine level to rule out acute kidney injury and urine analysis for proteinuria. Treatment strategies in hypertensive emergencies. Malignant hypertension and hypertensive encephalopathy. Reduce mean arterial pressure by 20 to 25% during the first hour and then aim for blood pressure of 160 over 100 mmHg during the following 2 to 6 hours. Preferred intravenous drugs are labetalol or nicardipine. Acute hemorrhagic stroke. If the systolic blood pressure is greater than 220 mmHg or between 180 to 220 mmHg, consider lowering the systolic blood pressure to between 140 to 180 mmHg and avoid systolic blood pressure below 140 mmHg. Acute ischemic stroke. If the patient is eligible for thrombolytic therapy, lower systolic blood pressure to less than 185 mmHg and diastolic blood pressure to less than 110 mmHg before thrombolytic therapy, and maintain blood pressure to less than 180 over 105 mmHg for the first 24 hours after thrombolytic therapy. If thrombolysis is not indicated and if blood pressure is greater than 220 over 120 or there is evidence of target organ damage, lower the blood pressure by 15% in 1 hour. And if the blood pressure is less than 220 over 120 and there is no evidence of target organ damage, no intervention is recommended for 48 to 72 hours. Preferred IV drugs in case of acute ischemic stroke and hemorrhagic stroke are IV labetalol or nicardipine. Acute coronary syndrome. Aim to reduce systolic blood pressure to less than 140 mmHg during the first 1 hour. Preferred drugs are IV sodium nitroprusside, IV nitroglycerin or labetalol. Acute cardiogenic pulmonary edema. Aim to reduce systolic blood pressure to less than 140 mmHg in the first 1 hour. Preferred drugs are IV nitroglycerin along with a loop diuretic. Aortic dissection. Aim to reduce systolic blood pressure to less than 120 mmHg and heart rate to less than 60 beats per minute during the first 1 hour. Preferred drugs are IV esmolol or labetalol along with IV nitroglycerin or nicardipine. Pre-eclampsia and eclampsia. Aim to reduce systolic blood pressure to less than 160 mmHg and diastolic blood pressure to less than 105 mmHg during the first 1 hour. Preferred drugs are IV labetalol with IV magnesium sulfate or IV nicardipine and IV magnesium sulfate. Laboratory evaluation consists of getting a complete blood count, complete metabolic panel, quantitative analysis for protein, cardiac markers such as troponin I, EKG for evaluation of cardiac arrhythmias and ischemia, fundoscopic exam for retinopathy, chest X-ray for evaluation of pulmonary edema, transthoracic echocardiogram for evaluation of cardiac function and structure, CT scan of brain and MRI of the brain for evaluation of stroke, intracranial hemorrhage and hypertensive encephalopathy, CT angiogram of chest and abdomen for evaluation of acute aortic dissection, renal ultrasound for evaluation of renal artery stenosis, other blood tests such as plasma metanephrines and urine metanephrines for evaluation of pheochromocytoma, overnight dexamethasone suppression test for evaluation of Cushing's disease. Intravenous antihypertensive drugs for the treatment of hypertensive emergencies. Labetalol. It's a combined non-selective beta blocker and alpha-1 blocker. It decreases the afterload and cardiac output. Its onset of action is 5 to 10 minutes and duration is 3 to 6 hours. It is given as 10 to 20 milligrams intravenous bolus every 10 minutes, followed by intravenous infusion at a rate of 5 to 20 milligrams per hour, up to a maximum of 300 milligrams. It is contraindicated in patients with acute heart failure, bradycardia, second degree or third degree AV block, and asthma. Nicardipine. It is a dihydropyridine calcium channel blocker with vasodilator properties. It decreases after load. Onset of action is 5 to 15 minutes and duration is 1 to 4 hours. It is given as 5 to 15 milligrams per hour IV drip. It is contraindicated in patients with acute coronary ischemia because of reflex tachycardia and in patients with severe aortic stenosis. Clevidipine. It is a dihydropyridine calcium channel blocker with vasodilator properties. It decreases the afterload. Has got rapid onset within 2 to 4 minutes and rapid offset with 5 to 15 minutes. It is given in a dose of 1 to 16 milligrams per hour IV drip. It is contraindicated in patients with acute coronary ischemia. IV nitroglycerin. It is a mixed venous and arteriolar dilator with predominant venous effect. It decreases the preload. Its onset of action is 3 to 5 minutes and duration is also 3 to 5 minutes. It is given in a dose of 5 to 200 micrograms per minute. It is contraindicated in patients with right ventricular infarction. IV nitroprusside. It's a direct vasodilator with predominant arteriolar effects. It decreases the afterload. It's got rapid onset and offset of 1 to 2 minutes. It is given in a dose of 0.5 to 10 micrograms per kg per minute as an IV drip. It is contraindicated in pregnancy due to risk of fetal cyanide toxicity. It can result in thiocyanide toxicity in patients with impaired renal function and can lead to cyanide toxicity in patients with liver disease.